Well, here we are back for part 2 of chapter 23's Gynecological Emergencies. We're going to pick up essentially right where we left off with a discussion about ovarian cysts, and then we'll move on into some deeper topics. An ovarian cyst is simply a fluid-filled sac that forms on either the inside, on the side, or on the inside of an ovary. Sorry, that's a little confusing. So it either forms on an ovary or inside of an ovary. They're very common, and they can develop whether a follicle releases an egg or not. So there might only be one cyst, or there could be several cysts that can develop. They can show up on one or even both ovaries at the same time. Most of the time these cysts don't cause any symptoms, and they're usually trouble-free, and they oftentimes go away on their own in about 8 to 12 weeks. However, if they do get big enough, they can cause some issues like pelvic pain, frequent urination or trouble urinating, and maybe even irregular periods because they begin to affect how the ovaries function. Ovarian cysts can rupture, and the symptoms of a rupture usually sneak up rather slowly. Patients often mention a heaviness or a full feeling in their lower abdomen or pelvis. And a rupture might happen on its own, or it could be triggered by something minor like light trauma, exercise, and even sex can trigger it. If a cyst does rupture, the patient may not notice anything at all, or they might have mild to maybe even severe symptoms. A common complaint is sudden sharp pain in the lower abdomen. This pain can also shoot into the back. If there's significant internal bleeding, you need to watch for signs of shock, like feeling faint, drop in blood pressure, even a fast heart rate, because blood loss is a very, very real risk. Ovarian torsion, on the other hand, is when the ovary twists and cuts off its own blood supply. We're going to suspect this if a patient has intense lower abdominal pain that seems to be getting worse. It's more likely in someone with a history of ovarian cysts than it is just kind of randomly on its own. Of course, this is a surgical emergency, and delays can lead to permanent damage of the ovary, so these need to be treated quickly. The pain associated with ovarian torsion usually comes on suddenly, and it can be moderate to severe on one side of the lower abdomen that builds over the course of a few hours. The pain can come and go, and it may spread to the back, the pelvis, or even the thigh where it gets a little referred. Nausea and vomit are very common side effects. The abdomen is often tender when you palpate it, and you might feel a mass. But even if there's no tenderness or mass, you can't rule out torsion. Pre-hospital treatment of a ruptured cyst or a torsion is essentially to recognize those early signs and symptoms and get them transported to the emergency department while managing the symptoms as best you can along the way. Uterine disorders such as endometriosis is an inflammatory irritation of the endometrium, or the lining of the uterus. It's a most common infection after childbirth. Symptoms typically show up within 36 hours of delivery. Symptoms oftentimes include fever, chills, nausea, vomiting, fast heart rate, a painful or cramping feeling in the lower abdomen or pelvis, and there's usually an accompanying, foul-smelling discharge. Calm reassurance will aid in the management of these patients. Make sure they're placed in a position of comfort during transport. Start an IV because that could be helpful. Endometriosis is typically treated with antibiotics in the hospital and sometimes even out of the hospital. However, if untreated, it can lead to serious complications like widespread infection or even sepsis. Endometriosis, on the other hand, occurs when tissue similar to the uterine lining actually grows outside of the uterus. This tissue can often be found on nearby organs like the ovaries, fallopian tubes, and even the bowel or the rectum, can have this tissue growing there. Many women don't discover that they have endometriosis until they experience trouble conceiving children. Common patient complaints include pain, which is the most frequent symptom, and it's often located in the lower back, in the pelvic area, and the abdomen. Other signs and symptoms may include unusually heavy or long periods, severe or worsening menstrual cramps. They may even complain of pain during sex. They can have a feeling of rectal pressure or the urge to have a bowel movement at unusual times. Fatigue, which might be confused with chronic fatigue syndrome, could be present. And then they might even have some spotting or light bleeding in between periods. Pre-hospital care for endometriosis should be generally guided by what the patient is experiencing and treating those symptoms as they come up. If the patient's in a lot of pain, you can give pain medications if protocol allows it. Let the patient find their position of comfort, and of course use towels or dressings to manage any heavy bleeding. A uterine prolapse happens when part or all of the uterus slips down and into or even outside of the vaginal opening. It's usually due to weakened support structures like muscles and ligaments and those connective tissues that normally hold the uterus in place. Those fail and the uterus essentially falls and prolapses. Some common risk factors for prolapse include a family history of it. There may be some genetics in play. Obesity, low estrogen levels, which can weaken pelvic support. Pressures from pregnancy, and a tough or traumatic childbirth history. Patients with uterine prolapse might describe things like a sensation of a heaviness or a fullness in the pelvis. They may feel unusually tired, and they may have an achy pain in the lower back. Standing for long periods of time tend to make the symptoms much worse, and lying down oftentimes brings some form of relief. When managing a uterine prolapse, we never try to push the uterus back into place. Instead, what we're going to do is we're going to gently cover that area with a warm, moist dressing and get the patient to the hospital as quickly as we can for further treatment and evaluation. Vaginal bleeding, on the other hand, is not typically a life-threatening thing, at least not with non-pregnant patients. In early pregnancies, it might go unnoticed even if the woman doesn't know she's pregnant, because that light bleeding might be confused with something normal going on. Dysfunctional uterine bleeding is when the bleeding is too heavy or happens too often, or when it shouldn't happen. It's diagnosed after ruling out other causes like medications or diseases that may be causing that. Typically happens when hormonal regulation of the menstrual cycle is kind of out of whack. We most commonly see this when someone is first starting menstruation, or when someone is maybe going through menopause, when the hormonal regulations kind of are out of whack. They're fluctuating and happening, causing odd things to happen, which can lead to heavy bleeding when it normally shouldn't be. Common risk factors for dysfunctional uterine bleeding could have perhaps, outside of those starting and or going through menopause, could be some significant weight changes, of course, being over the age of 40. Chronic stress could have some polycystic ovarian syndrome, maybe long-term use of birth control pills, maybe intense physical activity, and maybe some structural changes to the uterus that may be caused by some fibroids. Treatment for uterine bleeding might include hormone therapy or even surgery, depending on the cause. In the field, for us in EMS, we're going to focus on keeping the patient stable and comfortable until we can get them to that definitive care that they need. Traumatic vaginal bleeding, on the other hand, is not uncommon after things such as vigorous voluntary sexual intercourse. Although we need to be wary of the fact that it could be a violent involuntary activity that may have caused this. Some other things that might cause traumatic vaginal bleeding, of course, is a straddle type injury. A pelvic fracture can cause this. Direct blow to the perineum, foreign body insertion, or even abortion attempts might cause some traumatic vaginal bleeding. These kinds of injuries can lead to serious complications like heavy bleeding, organ damage, and even hypovolemic shock. In severe cases, there's a risk of full-blown hemorrhagic shock, which is a true medical emergency, and we should be prepared to treat it as such. An ectopic pregnancy happens when a fertilized egg implants somewhere it shouldn't, and this usually happens in a fallopian tube, not always. It can also settle in the abdomen, the cervix, or even an ovary, and it can get really dangerous really fast. An ectopic pregnancy should be considered a serious and potentially life-threatening situation because of the bleeding that can occur. Risk factors for an ectopic pregnancy include anything that causes scarring or inflammation in that fallopian tract, in that tract that egg's going to take. So there may be something like a past ectopic pregnancy, maybe a pelvic inflammatory disease history, maybe a history of tubal ligation, or even some surgical adhesions that may increase the risk of an ectopic pregnancy. If a fertilized egg settles in a fallopian tube, it will start to stretch the tube as it grows, which can lead to rupture, severe pain, and even dangerous internal bleeding. Some red flags that we should watch out for are complaints of belly pain, along with a late or missed period, and light spotting about 6 or 8 weeks after the normal period. So we're going to start to see these serious signs and symptoms of ectopic pregnancy show up 6 to 8 weeks after that missed period. Most people with an ectopic pregnancy show up with lower belly pain, usually more focused on one side. It might start out as dull, then turn kind of crampy or sharp as the fallopian tube stretches. If it ruptures, the pain can get extremely intense. And if there's internal bleeding, some might even feel pain in the shoulder because of the irritation that the blood causes on the diaphragm. When managing a suspected ectopic pregnancy, you should make sure you maintain a good airway and provide supplemental oxygen as needed. Position the patient in the left lateral recumbent position. Begin fluid therapy with large bore IVs and prepare for potential vomiting. Keep the patient warm. Apply the cardiac monitor and watch the EKG. And of course, urgently transport the patient to a facility that has surgical capabilities. An ectopic pregnancy is a true life-threatening emergency. So remember, time is of the essence with these patients, and transporting them to a facility that can handle that patient is essential as well. Be sure to give the hospital a heads up while you're on your way, letting them know what you suspect is going on, how the patient's doing, and an approximate time of when you'll arrive. Along the way, make sure you keep an eye on the vital signs and reassess the patient frequently during transport. Sexual assaults, we'll start off with a couple of definitions here. The Department of Justice defines a sexual assault as any sexual act without consent, including when the person cannot consent at all. The CDC adds a little bit to this and says that any unwanted sexual act, whether the person said no or if they're not able to say no, is considered a sexual assault. Now, rape, on the other hand, usually means a non-consensual penetration using force, threats, or when the victim cannot give consent. So that's kind of the definitions that we generally go by when it's related to sexual assault. And remember, rape's going to fall under that sexual assault banner. These situations are really, really complex. They involve, medical needs, emotional needs, and then they have a big legal element to them as well. So they can be difficult to manage at best. So how you treat the patient can have long-lasting impacts for them and for you. It's important to be professional, respectful, and gentle at all times. Remember, both men and women can be victims. So if you can, try to have a female paramedic with a female patient, and always invite law enforcement to have a presence there whenever you're dealing with a sexual assault. When assessing a sexual assault victim, only do a quick check for anything life-threatening. Don't get too invasive. If possible, if you have someone of the opposite sex available, ask that patient if they would prefer a male or female paramedic. Remember, you have to be cautious. You can't lower the standard of care. So if your partner is of the opposite sex of you, but yet they're not trained at the same level as you, remember, you can't downgrade your care. It doesn't mean that your partner couldn't be a part of that, and their communication with the patient might not be beneficial as well. So evidence preservation should come to mind whenever we're dealing with these patients. So kind of keep that in the forefront of what you're doing, is the thought of preserving evidence. Only examine the vaginal area if there is visible signs of bleeding. And of course, make privacy your top priority. You do not want these patients to feel like they're being victimized a second time during the process of reporting the crime that happened to them. Minimize the number of people in the rooms, because that can be very, very helpful. And of course, you're going to do a lot of this based on the input that you're getting from the patient. Some patients are very open and forthcoming with information. Other patients are going to hold back, and they're going to be very, very traumatized. Keep in mind that these patients will need both medical and emotional support. So don't try to question them like you're in law enforcement. You're not the detective. You're not trying to solve the crime. Don't do that. What you need to do is be really, really careful that you're not giving them the feeling that you're judging them. And you also need to make sure that you're shielding them from judgment that may be assumed, or that they're assuming others might be judging them. So you need to kind of protect them from others, passing judgment upon them. Watch for signs that maybe a date rape or club drugs may have been used. The patient may not know that drugs were involved, but having a memory loss of the situation is a big red flag. Common drugs include things like Rohypnol, GHB, ketamine, Xanax, Klonopin, and even alcohol. If these drugs are still active, you might see low blood pressure, slow heart rate, even some trouble breathing, and seizures and even a coma might not be completely out of the question if these drugs have been used. Remember, it is your job to preserve evidence. Avoid cutting through clothing or throwing anything away at the scene. Instead, put all blood-stained items in separate plastic bags, never plastic, because if you put them in plastic bags, they will mold. The blood will mold, and a paper bag will allow the blood to dry without molding and damaging evidence. Encourage the patient not to clean themselves, use hand sanitizer, go to the bathroom, change clothes, even have a bowel movement, or use mouthwash or rinse their mouth. All of these places could contain evidence that may ultimately provide some vindication for that person that has, been assaulted. Always respect how the patient feels. Never force them to do or not do something that they really feel compelled to do. But you might inform them that, hey, look, if you do that, you may destroy valuable evidence. They may not care. Some may not want to even be transported, and that's their right. Doesn't necessarily mean they have to be transported to the hospital. Evidence can still be collected without them going to the hospital. It's just maybe not the more invasive evidence. As long as they're a competent adult, they can refuse to be transported. So follow your local protocols for the treatment and refusal process in those cases. But of course, never just say okay and leave them at the scene. Make sure you document appropriately and you let them know the good, the bad, and the ugly about not going to the hospital for further treatment. Of course, you can still offer to contact a local rape crisis center for them and help get them in touch with a professional. Most victims are examined by specifically trained professionals when they do get to the hospital. So these professionals actually know how to handle these situations. They're trained sexual assault nurse examiners. Sometimes sharing that with the patients as well is oftentimes helpful, so they understand that they're going to be examined by someone that knows what they're doing. Always follow your agency's specific protocol for these situations. Some systems, some may allow for sedation if necessary. So know your guidelines. Most places don't allow you to sedate the patients, especially if there's even the hint that there may be some blood work needed to determine whether or not illicit drugs were used in the assault. So it just may not be a good idea to provide sedation. Remember when the patient care report, remember that patient care report is a legal document, so treat it carefully. You'll probably wind up in court. Keep your comments or keep your documentation short and directly to the point, and only include what the patient says in their exact words and in quotation marks what they say. Leave out your personal opinions and only stick to the facts. Of course, during your physical exam, document key details that need to be documented, like how the patient seemed emotionally, the condition of their clothing, and any obvious visible injuries that you might see are really noteworthy for documenting. Intimate partner violence includes physical, sexual, emotional abuse by a current or former partner or spouse. It can happen in both heterosexual and same-sex relationships, and it doesn't require sexual contact. Of course, remember, your top priority in these situations is safety. Not only the patient's, but especially your safety and your partner's safety are a top priority. All right, that is the end of chapter 23, and we will be back for chapter 24.